I'd like to start by thanking the organizers for inviting me to speak to you today about iron overload and iron toxicity. We'll start with a brief introduction to iron transport and metabolism in humans. So, to start with, humans only absorb about 2 milligrams of iron per day, and they lose 2 milligrams of iron per day. From every 3 days, you lose the whole lining of your intestinal tract and lose iron in those cells. When people are transfused, each cc of packed cells contains 0.8 of a milligram of iron, so one bag of blood provides 240 milligrams of iron. So multiple transfusions gives you a lot of iron. Humans have no way to excrete excess iron. Iron accumulation in the heart and the endocrine glands depends really greatly on marrow activity and is not directly related to how much total body iron you have. So this complicates monitoring patients when we treat them. Before we had effective chelator medications to remove iron, the patients on chronic transfusions died by the age of 15 years old, secondary to cardiac iron overload, heart failure, and diabetes. In 2020, these patients have a normal life expectancy, so they're exposed to iron for much longer periods of time. So let's talk a little bit about iron absorption. This is really the only way humans have to regulate the intake of iron into their bodies. And so iron in the intestinal tract is converted into Fe+2 and comes into the lining cells here of their intestines, of their duodenum, where it's either stored as ferritin or it is exported through the only known iron transporter in humans called ferroportin. Now, your liver senses the amount of iron bound to transferrin, and if the iron level if there's too much iron around, then it secretes this peptide called hepcidin, which causes this exporter to be internalized and blocks the exit of iron from the duodenal cells into the blood. This is how you regulate iron uptake. If you have too much iron, then you block the export from the endothelial cells of the intestine, and then these are sloughed in the stool, and all the iron that accumulated there goes out with it. Now, I'm going to walk you slowly through this slide about what happens once the iron gets into your body. Normally, the iron is bound to transferrin. It's converted so the toxic form of iron, which is Fe+2, is converted into ferric iron and bound to transferrin. And there are receptors on the surface of the cells that the transferrin binds to, and this iron transferrin complex are brought into the cell, as you see here, and the iron is deposited intracellularly. Now, there's a really amazing mechanism that senses how much iron is intracellular, and if there's too much iron, you stop producing this receptor, and that blocks the influx of iron through this normal regulated mechanism. So this is highly regulated, and through this mechanism, you cannot become iron overloaded. Now, there's a catch here, and that all the cells of your body have other kinds of transporters that transport divalent ions like copper, zinc, and calcium, predominantly calcium. And since any iron, therefore, that's in the +2 state, not the +3, can be transported through these calcium and zinc transporters and get into the cell. And these transporters are not regulated with respect to iron. So circulating non-transferrin bound iron and the Fe+2 subspecies of this, labile plasma iron, enter cells through calcium transporters, and particularly in the heart through L-type calcium channels, and in the endocrine organs also through calcium channels. Now, normally, circulating iron binds to transferrin, and about 30% of this protein is bound. However, patients that are multiply transfused and have excess iron develop very high levels of transferrin saturation. Once about 80% of the transferrin becomes saturated, then this non-transferrin bound iron spills over into the plasma. So you have a lot of circulating non-transferrin bound iron, which then enters the cells with these calcium transporters. Normally, red blood cells that are transfused or that are made by the bone marrow go into the macrophages in the reticuloendothelial system and are digested. And the iron is recycled, and the iron comes back out into the plasma through ferroportin again, binds to transferrin, and goes on to make more red cells. And the active bone marrow normally uses about 25 milligrams of iron a day to make red cells. However, if you have ineffective erythropoiesis, ineffective production of red cells, such as the case in thalassemia, or you aren't making red cells at all, like in aplastic anemia or certain congenital marrow failure syndromes, then you do not utilize this excess iron. And the end result is even more circulating non-transferrin bound iron because it's not being used. And in these kinds of states, when the marrow is dysfunctional like that, you really load the heart and the endocrine organs like crazy because you have a lot of circulating ferrous iron that enters through calcium transporters. And this is really the only way that pathologic iron gets into the heart and the endocrine organs. Normally, humans do not have any circulating non-transferrin bound iron, or extremely low levels of it. Only in pathological states like you see with multiple blood transfusions and certain other disorders. So iron goes very rapidly into the body, and this graph in the upper right-hand corner shows this. You can see the liver iron going up very rapidly over a number of years, from 2.5 times normal to 30 times normal. We can monitor iron in organs by magnetic resonance imaging, and that's what we've done here. And what you can see is several years later, the pancreas in this line starts to go up, the iron loads there. And lastly, we have iron loading in the heart. So organs of the body load iron at different rates, which again complicates the treatment of the disorder. You can't just look at their total body iron measurements. You have to look at each individual organ. This is a magnetic resonance image. Here you have the liver, which is very black, and when this black on the MRI means there's a ton of iron there. And you can see the myocardium here in the heart also is black, so there's iron in the heart. Now, when you tell a patient that they have a lot of iron in their heart, that usually stimulates them to start taking the medication you prescribed to remove iron. And you can see in the same patient 6 months later, the liver is now gray. They've lost the iron in the liver, but the heart is even worse. So this makes the point that the exit from different organs of iron is also different. And the liver can drop its total iron by 50% in 4 to 6 months, whereas the heart requires 13 to 16 months in order to lose half of its iron. So these differences in loading and differences in exit of iron from the different organs complicate very much monitoring patients when we're trying to get rid of excess iron. Now, just to make the point a little bit more about the importance of bone marrow activity in regulating this whole thing, on the left-hand panel here, you see the transferrin saturation, which is a commonly done blood test, versus the non-transferrin bound iron levels that we've been talking about, which is a research test. And you can see once the transferrin saturation hits 80%, there's a ton of circulating toxic NTBI. In the right-hand panel, we see bone marrow transplant patients. And you get chemotherapy and prior to bone marrow transplant to kill the bone marrow. So when you give the graft the bone marrow intravenously, it has an empty marrow to go into and to grow. And these are 4 different chemos of different intensities. And you can see here that 3 or 4 days after starting the chemotherapy, the transferrin saturations go from normal up to nearly 100% because you've killed all the red cells. And similarly, when the marrow recovers, which you see over here with the milder chemotherapy, these levels come back down again as the marrow activity comes back and you start to use the iron. So the bottom line here is you don't need to be iron overloaded to get significant elevations in toxic labile plasma iron. Just killing your bone marrow or having your marrow stop for some reason can cause that to happen as well. To drive this story home a little bit farther here, we've plotted the liver iron here, the pancreatic iron and the cardiac iron on the y-axis. Remember, pancreas and heart only load when there's circulating non-transferrin bound iron. You can see that the patients in red are patients with sickle cell disease who have very active, effective bone marrows. They're making tons of red cells, whereas the patients in black, particularly thalassemia major, are very ineffective, and they are not making red cells very well. You can see the liver loads the same for both groups, but when you look at the pancreas and heart, the sickle cell patients don't load at all with the effective bone marrows, but the patients that have ineffective erythropoiesis have substantial loading into their endocrine organs, their pancreas, and substantial loading into their heart. So where the iron goes depends upon the bone marrow activity. If you have iron in your pancreas, if you have iron in your heart, it means you've had prolonged exposure to circulating non-transferrin bound iron. So iron toxicity is related to a few things, but most notably it's related to how much toxic iron is in the bone marrow and how long it's there. Those are the two major factors that are important. And the circulating toxic iron, the labile plasma iron, one of the good things about this is it can be immediately removed, whereas the iron that's in the tissue takes much longer. Now, the critical point about having ferrous iron around, or this not labile plasma iron, is that it interacts with hydrogen peroxide, which is a major inflammatory chemical that's produced to fight infections and inflammatory states. And this hydrogen peroxide interacts with this ferrous iron and makes hydroxyl radical and singlet oxygen. And these are the most powerful oxidants known to man. They cause DNA damage, protein damage, fibrosis, all kinds of things. And so this is the enemy. When we're trying to treat these patients, we're trying to reduce ferrous iron to keep it from interacting with hydrogen peroxide and causing tissue damage through production of powerful oxidants. So let's take a look at the clinical manifestations of this. If we take thalassemia major, these are patients transfused every 3 weeks, and they have ineffective bone marrow activity. And sickle cell patients also require transfusions periodically, but they have very effective production of red cells. And these two groups of patients have identical total body iron. They have 14 milligrams of iron per gram dry weight of liver. Normal is 1.5. But what's obvious from this graph is that the thalassemia patients have all kinds of damage to their heart and their gonads, whereas sickle cell patients have none. Why is that? It's because thalassemia patients have high ferrous iron, high labile plasma iron, and sickle cell patients do not because of their very active bone marrow activity. So again, the organ damage is related to marrow activity in the presence of these toxic species. Now, chelators in the upper right-hand corner here, we see the blood levels of desferoxamine, which is a chelator given here, in this case, by continuous infusion. So you turn on the IV, the level goes up, it stays up. You turn off the IV and it drops back down again. And you can see the non-transferrin bound iron, or the toxic iron levels, drop immediately when the chelator is present. They stay down as long as the chelator is circulating, and they come back up again as soon as you stop it. So we can get rid of this circulating pool of iron that causes damage and that goes into cells by having chelators circulating all the time. If we look down here in the bottom panel, this is just a different chelator that you give 3 times a day, the Ferroprox, and you can see you give the chelator here and the NTBI levels drop. You give the chelator here, and then at the peak of the chelator, the levels drop. So the pattern of clearance of toxic iron is really related to the plasma level of chelators. The first goal of chelation is to protect against oxidant damage. The secondary goal is to remove the iron from the body. This is an experiment a study where they gave continuous desferal to patients that had heart failure secondary to iron overload. And you can see here, cardiac T2 star, which is a measure of iron, is very low at 5. Normal is 30. These patients have a ton of iron in their heart. They have a ton of iron in their liver. Normal liver iron is 1.5. And these patients' ejection fraction is significantly decreased, 52%. That's the function of the heart. Continuously infusion of desferal, and you can see 3 months later, the T2 star is higher, meaning less iron. A little bit is gone. The liver iron is better. The cardiac function is now normal. Even though the iron is still very high in the heart, the function is normal because you remove circulating iron, circulating toxic iron. And a year later, you see the same thing. You still have very high levels of cardiac iron and normal cardiac function. So the moral of the story is chelating toxic circulating iron corrects organ function long before the tissue iron is reduced. How do we monitor iron overload in patients? I don't have time to talk about this very much, but ferritin is a simple blood test, but it's very inaccurate. Transferrin saturation measures a toxic iron, but it's very variable, not very helpful. The main thing we do is magnetic resonance imaging. It has a low coefficient of variation, and we can directly measure the non-toxic form of iron in the organs, various organs of the body. And this is standard of care, critical in patients with thalassemia, and we have a lot of transfusions. So if you get rid of the iron, does this matter? Does it help at all? The answer is yes. This is the mortality in thalassemia patients. In 2004, you see a 71% reduction. This is coincident with the advent of 2 chelators of desferal and Therapox, and also when we started to be able to measure iron using MRI to adequately treat them. So substantial reduction, and all of this death was reduced because of cardiac deaths. If we look at endocrine function, here you see these bars, the white bars are insulin secretion. In patients who've had their liver irons drop down into the normal range, less than 1.2 milligrams per gram dry weight. If we look in the bottom panel, 66% afterwards have normal glucose metabolism. 30% still require testosterone replacement compared to 60% before. And thyroid replacement is only required in 16% compared to 36% before removing the iron. So their endocrine function can improve. This is survival after bone marrow transplant in adults with acute myeloid leukemia. You can see here in patients that were chelated, this is the cumulative incidence of relapse, and you see that the relapse rate is much higher in patients that were not chelated compared to patients that were chelated. So remember, the toxic oxidants produced by iron cause DNA damage. I'll show you some more data on this in a second. This is my favorite study, as a matter of fact. This is 1,200 men in their 60s who were randomized to have phlebotomy, had blood drawn to remove iron. 600 got phlebotomy, 600 didn't. The ferritin level was 122 in those who did not receive phlebotomy, and it was dropped down to 80 in those that did. For comparison, patients with thalassemia often have ferritins in the thousands. They thought that this was going to help their hearts. It had no effect whatsoever on cardiac function, but there was a 30% reduction in all types of cancers. 30%, less colon cancer, pancreatic cancer, less liver cancer. And there was a 60% reduction in death from cancer from a very small reduction in total body iron. This is an epidemiologic study of patients with thalassemia in their 50s and 60s. What happens if you're exposed to low levels of iron or moderate levels of iron for long periods of time? And overall, patients with thalassemia, if you look at cancer of the abdomen, except for prostate, you see that these patients have a twofold increased risk that thalassemia patients who are iron loaded, by the way, have a twofold increased risk of cancer. And if you look at hematologic malignancies, they have a 5 times increased risk of leukemia. Now, thalassemia patients develop iron overload, even if they're not transfused, by the way. If we compare cancer risk in thalassemia patients who were transfused versus those who were not, the transfused patients have a 7 times higher risk of cancer. If you look at abdominal cancer, they have a 9 times increased risk. If you look at hematologic malignancy, they have a 9 times increased risk. So transfusion increases the risk of cancer over decades. So, concluding points, iron toxicity is related to the amount of iron there and how long it's there. Non-transferrin bound iron is the toxic form of iron that we're trying to protect the patients against by chelating. The amount of loading that goes into various organs, especially the heart and pancreas, is highly dependent upon their bone marrow function. And the other really important point is these patients are now living decades. They're living into their 60s and 70s. And so we really need to make sure that we control their iron and control it well for a long time to prevent them from getting long-time complications. Now that they're surviving heart failure and diabetes, they're living long enough to get malignancy. So they need to be followed very carefully by people who understand these processes. So thank you for your attention.